So today my lecture or didactic will be on pharmacology of benzodiazepine. So just to brief you about how the outline will be, it will be introduction, including a very brief history because we have limited 15 minutes time. I'll be talking in depth about pharmacology of benzodiazepines, how they act at a molecular level and what are the physiological changes associated with them. I'll be talking about psychopathology, that is the sedative and hypnotic use disorders or the dependence that is there in ICD-11 and DSM-5. And then I'll be concluding with take-home points. Right. So just for the introduction part, it was introduced earlier. The age of anxiety was in 1980s, where benzodiazepines were the premier minor tranquilizers, and it was initially marketed as a safer alternatives for barbiturates. Because barbiturates initially when it was produced in I think by the brand name Barbital in 1903, they had a very low therapeutic index and overdose was very frequent with them, which resulted in respiratory depression and death. In Indian context, if we talk about, according to the National Drug Use Survey in 2019 by Ambekar et al., benzodiazepine use disorder has a prevalence of 1.08%, affecting approximately 1.18 crore individuals in India. And this figure has risen in the last 1 decade or so. So now the latest figures that I was reading was around 1.5 to 1.6 crore individuals. So coming to the minor difference, these are the two terms that we use very interchangeably, sedatives and hypnotics. So what is the difference? So sedative is basically a drug that decreases activity, moderates excitement, and calms the recipient. Hypnotic is something that produces drowsiness and it facilitates the onset and maintenance of a state of sleep that resembles natural sleep in its EEG characteristics and from which the recipient can be aroused easily. So this is the basic difference between sedative and hypnotic. But again, in terms of benzodiazepine, these terms have been used interchangeably. Coming to the history, so all the drugs that I've mentioned on the screen here, alcohol, opium, bromide, chloral hydrate or paraldehyde, even barbiturates, barbital, and meprobamate, these are the drugs which were used at certain point of time in history, in the late 18th century, earlier 19th century, and the 20th century for sleep induction or for sleep maintenance. Right. So these are the common things, but there were significant side effects of all the drugs. Alcohol, as we know, there was very significant withdrawal, not a very good way of inducing sleep. So that was discarded. Opium related toxicity and opium related respiratory depression and overdose was also one of the significant side effects that was noted. So again, opium was not a very good option for the sleep part. Again, bromide and chloral hydrate, they had multiple adulterants. That was one thing, and again, causes an irreversible comatose sort of a state. So that was the second thing why chloral hydrate, bromide, along with that barbiturates. Barbiturates also were not very useful in inducing sleep, although very potent, but again, comes with a very high degree of risk. Right. So that is how benzodiazepines came into the picture in somewhere around 1959 to 1961. So now coming to the pharmacology, benzodiazepine, as the name suggests, there is a benzene ring, and along with that, there is a 7-member diazepine ring. So hence the name, the benzodiazepine. So now if you see, there are multiple R chains. To be very precise, there are 6 or 7 R chains in that. So R side chain of benzodiazepine, these benzene and the diazepine rings, this is what determines the potency, efficacy, half-life, duration, other things of benzodiazepines. So most commonly we classify as per chemical modifications is the 2-keto group, the 3-hydroxy group, and the triazolo group. Triazolo groups are basically nitrogen containing side chains. 2-keto benzos include your chlordiazepoxide, diazepam, flurazepam, clonazepam, flunitrazepam. So if you look very closely, the 2-keto group, since there is a double bond, it takes too much of time to get metabolized. These are the classes which have longer acting benzodiazepines because they have one active metabolite, then they produce another active metabolite, and then finally they get converted into the excreted product. So these are the longest acting benzodiazepines in this class. Then we have the 3-hydroxybenzenes. Hydroxybenzenes, benzos, again, very easy to be metabolized. So that's why it is the lorazepam and the oxazepam. Now, recently, tenazepam is also considered as a part of 3-hydroxybenzenes. These are the benzenes which are very easy on the liver because, as we know, benzodiazepines go a two-phase metabolism in the liver. So the keto benzos have to go through both the stages, but the hydroxybenzos, they can skip the stage 1 metabolism. So the glucuronidation and the other CYP interactions are not very much with hydroxybenzos as compared to keto benzos. And then obviously we have the triazolobenzos, which are the very rapidly acting, short acting benzodiazepines, in which we have alprazolam and triazolam. So now this is the classification based on their chemical structure and molecular structure on the basis of side chains and other things. How do benzodiazepines act? So basically, to understand how benzodiazepines act, we have to understand that in our CNS system, there is a balance of glutamate and GABA. Glutamate is your excitatory neurotransmitter, the predominant excitatory neurotransmitter. Along with that, GABA is the predominant inhibitory neurotransmitter. So is GABA equal to benzodiazepines, or how do benzodiazepines modulate GABA? So benzodiazepines at a receptor level, they are a positive allosteric modulators of the GABA A receptors. So GABA receptors also, if we see the distribution, there are GABA A receptors and GABA B receptors, in which GABA A receptors are predominantly in the CNS. GABA B receptors have other functions also. So GABA A is the target area of benzodiazepines. Again, GABA A receptors, if we talk about how the chemical structure of GABA A receptor is, it is a pentameric chloride channel. And it's a pentameric chloride channel which can act in two ways. Either the frequency of the channel opening can increase to cause a hyperpolarization, or the duration of that channel opening can increase to cause a hyperpolarization in the following neurons. So this is where the difference in action between barbiturates and benzodiazepines happen. The benzodiazepine, when they come, they bind to the, so before I come to that, there are different subunits. There are alpha subunits 1 to 6, beta subunits 1 to 4. There are gamma subunits 1 to gamma 1 to 3, and then there are delta, epsilon, rho, and pi. In total, there are around 24 families of these subreceptors, right? And we need to have a 5 receptor combination to form one sort of a GABA A receptor, because it's a pentameric receptor. So alpha, beta, gamma, delta, in various combinations and permutations, they form different types of GABA receptors. So these GABA receptors are very specific in the sense these subunits, the alpha 1, alpha 2, beta 1, beta 2, are responsible for very selective actions in the body. So suppose if I just have to give you very small examples, alpha 1 is responsible for your sedation, your ataxia, and amnesia. So if a molecule comes and acts in a GABA receptor that has an alpha A1 subunit, alpha 1 subunit, then that will be responsible for your sedation, your amnesia, and your ataxia. If there are alpha 2 and alpha 3 subunits, so that will mediate your anxiolysis, that will mediate your muscle relaxation. If there is alpha 5, it is linked to again memory and cognitive impairment. Similarly, there are different roles of these different subunits that are there. Right. So when these benzodiazepines come, the benzodiazepines bind at the alpha and the gamma interface. GABA at the other end, they bind at the alpha and the beta interface. So there is a difference as to how GABA causes sleep and how the benzodiazepine is helping that. So benzodiazepines will be binding at the alpha and the gamma interface, whereas your GABA will come and they will bind at the alpha and the beta interface. So this is something important to remember, because this is how tolerance also develops to benzodiazepines. Because I will come and I'll speak to you about how the tolerance develops. But this is the same thing that I spoke to you about. Most common structure is the GABA A, which consists of 2 alpha, 2 beta, and 1 gamma subunit. So this is the most common. So if you just imagine it's a pentameric structure which has 2 alpha, 2 beta, and 1 gamma subunit. So there are 2 alpha beta interfaces and 1 alpha gamma interface. So GABA will bind at the alpha beta, whereas your benzodiazepines will bind at your alpha and the gamma interface. Correct. Other thing, benzodiazepine increases affinity to GABA A receptors for GABA. Yes, and increased frequency of chloride channel opening is how benzodiazepines work, that causes further hyperpolarization. These are the mechanism of action of different alpha 1, alpha 2, alpha 3, and alpha 5. Again, the predominant role is it has to cause hyperpolarization at the postsynaptic neuron. Again, so now if you look at these two pictures, one is in A, we show that there is no benzodiazepines, but in B, we see that there is a benzodiazepine that is there. So this is something called as inhibitory interneurons that are there in your reward pathways. So what happens usually is when benzodiazepine will come, it will block that interneuron, and there will be a very high surge of dopamine in your reward pathway. That is how benzodiazepines, people sometimes utilize benzodiazepines to give you that high. When people say that, there is a culture now when people say that I take nitrosun or I take nitrazepam to get that high. After taking nitrazepam, I feel very confident, I feel I can do things, and I feel very activated, I want to talk to people. This is how that is happening, and this is the high that people chase sometimes. So what benzodiazepines does at your mesolimbic system, it blocks your interneurons which were inhibiting your already active this reward pathway. So now your reward pathway is in a hyperdrive mode. So it's giving you a more sort of a kick. And that's why some people ask that how can a sedative or a benzodiazepine that is known to be an intrinsically depressant molecule give you a kick? This is the mechanism of how that kick happens with benzodiazepines. Right. So what are some of the physiological effects? These are very common things. I am sure everyone knows about it, but still. So again, it decreases sleep latency and number of awakenings, but it increases the total duration of sleep. That is one very common effect. What we see in clinical practice also, that when patients come to us next day morning, they will say that I took my medication at 8 o'clock or 10 o'clock at night, and I still feel sometimes very drowsy towards 10:30 or 11 o'clock in the morning. So basically what has happened is they were able to sleep very early, they were able to maintain their sleep, but they had persisting drowsiness after they are awake also. Then there is something, it causes your decreased stage 1 and stage 3 sleep, it increases your stage 2 sleep. Stage 2 sleep is where sometimes dreams and other things happen. So benzodiazepines sometimes are notorious in that way. The other thing that is important is it actually reduces the time that you spend in your deep sleep. So according to the new architecture of sleep, the N1, N2, and N3, if you look at the N3 part, which has the stage 3 and stage 4 of your NREM sleep, benzodiazepines actually reduce that part. So benzodiazepines are not known to cause very deep sleep, but it's known to cause prolonged sleep. And obviously it causes a REM rebound that happens. Sometimes benzodiazepines can lead to disinhibition or paradoxical rage. Sometimes you would have seen, just like with alcohol, sometimes this is the same mechanism that benzodiazepines can cause disinhibition or paradoxical rage reactions also. Then definitely in terms when people are misusing benzodiazepines, there is a risk of amnesia as well, because sometimes under intoxication there is difficulty in registration and recall, so it can cause an anterograde amnesia sort of a situation. Cognitive impairment, yes, it can affect learning, memory, attention, and visual spatial ability. That's why prescribing benzodiazepines in elderly is a special technique. I mean, we don't very usually prescribe benzodiazepines in elderly until and unless it's absolutely needed at that time. And obviously, one more function of benzodiazepines is muscle relaxation in the physiological systems. Respiratory system, it worsens your sleep related breathing disorders. So again, to be very careful in people who have been diagnosed with obstructive sleep apnea and other things, because it decreases the ventilatory responses to CO2, the hypercapnia drive that is there in the brain. It actually kills that drive. So even if the person is not breathing enough, the brain is not getting the signal that, okay, there is high carbon dioxide and low oxygen in your brain. So that drive cannot happen if there is benzodiazepines in the body. And that in turn leads to hypoventilation and hypoxia in cases of COPD or OSA for that matter. Cardiovascular system, again, midazolam is the safest in that case. But there are, midazolam is the riskiest, I'm sorry, midazolam is the riskiest in that case. Otherwise, it's usually doesn't have much effects, reduces blood pressure, can cause compensated tachycardia, but again, not much effects. GI tracts, it improves anxiety-related GI disorders, yes. Pharmacokinetics, again, I think I briefly spoke about this. So hepatic metabolism by hepatic CYP enzymes, dealkalization and aliphatic hydroxylation are, this is followed by conjugation. So the benzodiazepines that we talk about, the LOT group, the lorazepam, oxazepam, and temazepam, they undergo direct conjugation. They don't have to go the phase 1 reaction, and that's why they are easy on the liver. So people who have compensated liver cirrhosis or people who have other sort of liver pathology, alcohol related hepatitis or alcohol related decompensated liver cirrhosis, these are the drugs that can be chosen for that. Elimination half-life, again, depends on the rate of metabolic transformation. So most of the short-acting agents, they don't have any other active metabolite after that. Most of the intermediate and long-acting agents, such as your diazepam, chlordiazepoxide, they have other active metabolites in the form of oxazepam and other things. So that's why they have higher half-lives. Again, this is a table. So as I was mentioning, the diazepam and chlordiazepoxide, they get converted into nordazepam or demoxepam. And again, at the end, it gets converted into oxazepam. And that's why we can technically use oxazepam also as a drug. And I was surprised when I was doing reading on this material. Oxazepam was the third benzodiazepine to be actually marketed after diazepam and chlordiazepoxide. It was all way before lorazepam and clonazepam and other things. Right, so this was one of the first active metabolites that was discovered upon after chlordiazepoxide and diazepam, and similarly we can see for other things. Right, so therapeutic equivalent doses, that is important in cases sometimes when we are managing cases with benzodiazepine withdrawal, we have to calculate, we have to switch. If a person is taking very short acting or an intermediate acting sort of a benzodiazepine, we have to see that what are the equivalent doses of diazepam. So technically what we see is we convert it into 10 mg of diazepam. So 10 mg of diazepam is equal to 0.5 to 1 mg of clonazepam depending on the guidelines, is equivalent to 25 mg of chlordiazepoxide, is equal to 2 mg of lorazepam, to 30 of oxazepam, and so on, 10 mg of zolpidem, because now we have started seeing increasing cases of Z drug dependence also. So 1 mg, 10 mg of diazepam is equivalent to almost 7.5 to 10 mg of zolpidem. Again, these are the T halves of all the drugs, that we have just discussed, and the P450 enzymes, the CYP enzymes in which they are metabolized through. This is something important: the sedative, hypnotic, or anxiety use disorder, intoxication, and withdrawal. So basically, if we have to understand it very clearly, since alcohol has already been covered as a part of this course, it's very similar to alcohol, but there are certain significant differences that I will be mentioning. So these are all the specifiers that are there in ICD-11. There can be a single episode of harmful use. There can be a harmful pattern of use of sedatives. Then obviously there are dependence, intoxication, withdrawal, induced psychotic disorders, and induced other disorders. Right. So how do we say that a person is dependent, or what are the different types of dependence or use disorders in benzodiazepine? So these are the most three common types of patient that we see. So benzodiazepine use, was it prescribed currently? So yes. Was it being taken as per prescription? Yes or no. If it was being taken as per prescription, then physiological or psychological withdrawal. If it's not happening, it's fine. But suppose if it is happening, then it is something called a therapeutic dose dependence. Because I have prescribed clonazepam 1 mg for a person for a primary insomnia for sleep. But now the patient says that I have been taking 1 mg of clonazepam for at least last 8 weeks. I have been able to sleep well. I want to get off clonazepam. I am trying to reduce the clonazepam dose from 1 mg to 0.5, but I'm still not able to sleep. So what is that? So that is not a prescribed high dose dependence or a recreational abuse by the patient. That is a therapeutic dose dependence. So that is one type of patient that we see. The other type of patients is whom we had prescribed, but they are not taking as per prescriptions. So basically, they have comorbid anxiety, depression, or they are internalizing spectrum. They want to use benzodiazepines as a way of coping up. So most of the time they increase their dose to more than 40 milliequivalents of diazepam. So that is what we call as prescribed high dose dependence. This is the second group of patients that we see. The third group of patients, they were not prescribed benzodiazepines, or they were sometimes prescribed in the past. If they had been prescribed in the past and they are now using it without prescription, again, it will fall in the category of prescribed high dose dependence. But if they have not been prescribed in the past and younger age, externalizing spectrum, they are just using benzodiazepines to chase that high, as I mentioned, then this is something called as recreational abuse. Okay. Right. So what are the determinants of abuse? Why do people land into benzodiazepine abuse? So there is a positive reinforcement, specifically with nitrazepam, flunitrazepam, diazepam, alprazolam, and sometimes with lorazepam. Although lorazepam is said to be the most safest amongst these, but now reports are emerging of lorazepam dependence also. The rapidity of action. So most of the patients who get dependent, they want rapid acting, short acting benzodiazepines. So those are the like the alprazolams, your clonazepams, your midazolams. So people have higher tendency to abuse those drugs as compared to your diazepam and your chlordiazepoxide. Again, withdrawal symptoms. Withdrawal symptoms will depend on what sort of benzodiazepines you are taking, what is the route of your benzodiazepine use, and for how long you have been taking that benzodiazepine. Suppose alprazolam use, if you are taking somewhere around 4 to 5 mg of alprazolam, withdrawal symptoms can start within 12 to 48 hours, somewhere peak around 72 hours. But if you are taking a longer acting benzodiazepine, suppose diazepam or chlordiazepoxide or nitrazepam, sometimes you may not see acute withdrawal for as long as 4 to 5 days also, and acute withdrawal seizure or delirium might happen at a very late stage, sometimes after 7 days, sometimes at a range of 7 to 10 days. Again, you have to assess for comorbidities. If the person has anxiety, depression, other comorbid substance use disorders, or other internalizing sort of disorders, then there are higher rates that they might land in a state where they are benzodiazepine dependence. And again, high neuroticism has been a known risk factor as a determinant of abuse. Again, tolerance that I started speaking. So what are the ways in which we develop tolerance to benzodiazepine? The patient that I was mentioning, that he is taking 1 mg of clonazepam, but after 8 weeks, he wants to come out of it, he is not able to. That is one thing. Second time, sometimes they will come back and say that 1 mg, last 6 weeks I was sleeping well, but now I am not able to sleep well. So something that has changed in the neurochemistry and at a receptor level in the patient's brain. So tolerance has developed. So I told you that benzodiazepines are something that acts at alpha and gamma interface. Long-term use of benzodiazepine actually leads to a change in the intrinsic benzodiazepine pentamer. So sometimes the alpha gamma interface is gone in itself. So now it's only alpha and beta interface. That is one way in which patient develops tolerance. The second way in which patients develop tolerance is there is a down regulation of benzodiazepine receptors. So chronic use of benzodiazepine actually leads to a decrease in your benzodiazepine pentamers in your brain and areas which are known to induce sleep. And that's why one way of tolerance. The other way of tolerance is at the mRNA level. So the mRNAs involved in the synthesis of alpha-1 GABA A receptor are reduced and alpha-4 subunits are increased. So alpha-4 subunits are known to be resistant to benzodiazepines. So that's why. So these are some of the reasons why tolerance can develop to benzodiazepines. Right. In this slide, the last thing is tolerance develops then in the order. So what becomes tolerant first? What physiological effects become tolerant? So sedation is something, then after that amnesia, then anticonvulsant, and then anxiolytic. Withdrawal, as I told, the timeline, it depends on the agents that you are using. What happens in withdrawal, as I said in the starting of the presentation, basically brain is an intrinsic, inside the brain, the GABA and glutamate balance. Those are the two things. So glutamate, as the benzodiazepine increases, there leads to an increased level of GABA in the brain. To counter that GABA in the brain, glutamate also increases. But when there are conditions when there is a sudden GABA precipitation, or you have suddenly stop taking agents which are increasing your GABA facilitation in the brain, glutamate is at a higher state, and that glutamate excited toxicity is responsible for all the withdrawal symptoms. Right. So all the withdrawal symptoms like your anxiety, your tremors, your restlessness, you're not able to sleep, you're having perceptual disturbances. Sometimes you might land in a state of delirium, or you might throw a seizure. These are the physiological manifestations of glutamate excited toxicity in cases of withdrawal. Right. So what are some specific symptoms of benzodiazepine withdrawal? Mood and cognitive symptoms. Again, a very strange sense of dysphoria, anxiety, apprehension, irritability. There can be obsessive and depressive ruminations and paranoia also in certain cases. Sleep disturbances are the most common presentations, which include insomnia, altered sleep-wake cycle, and daytime drowsiness. Along with that, some physical symptoms like agitation, tachycardia, palpitations, restlessness. Again, there can be some myoclonus during the sleep time, nausea, coryza, diaphoresis, etc. Seizures, hyperreflexia, again very diagnostic of benzodiazepine withdrawal. Perceptual disturbances include your hyperacusis, your depersonalization, derealization phenomena, your blurred vision, illusions, and your hallucinations. Then there is a certain difference, although again used interchangeably, but there are differences between rebound symptoms and recurrent symptoms. So rebound symptoms are some things that return of symptoms in a more severe form for which the benzodiazepine was originally prescribed. So suppose I had anxiety disorder. Someone prescribed me clobazam. You take clobazam for 1 month, and then after that you come to me. So I was taking clobazam. I stopped clobazam, and then the symptoms were not just like how it was before, but it was very more severe as compared to before. It is something called as rebound symptoms. Then there is a recurrent symptoms, returns of original symptoms, or they're below their intensity. Again, and then third type of symptoms are the discontinuation symptoms or the withdrawal symptoms. Symptoms common to all the anxiety states and symptoms less common in anxiety states relatively that are specific to benzodiazepine withdrawal. Again, as we spoke, perceptual distortions, the depersonalizations, the hallucinations, the formications, the sensory hypersensitivity, the muscle twitches or the myoclonus. So to monitor the benzodiazepine withdrawal, I think this is a scale that we all are aware of. This is CIVA-B. It can be divided into objective and subjective, and then obviously monitoring CIVA-B less than 20 is mild, 20 to 40 is moderate, and more than 40 is severe. Again, intoxication, very similar to alcohol. You will have slurred speech, you can have blurred visions, incoordination, unsteady gait. You can have nystagmus, impairment in cognition, and it can lead to a stuporous or a comatose state. Toxicity or adverse effects, yes, it can cause oversedation, very common, memory impairment and paradoxical rages. Paradoxical rage, not so common. Drug interactions, yes, the CYP enzymes, most of the, sometimes when we are prescribing fluoxetine or the other CYP inhibitors, we have to be conscious because they will inhibit CYP and they might lead to increased levels of benzodiazepines in your serum. Then again, in depression, there is a risk of self-harm with benzodiazepines, so we have to be cautious in prescribing benzodiazepines. Effective in elderly, again, it can lead to a certain degree of cognitive slowing. It can worsen the pre-existing cognitive side effects. It can lead to falls. So again, to be very cautious while prescribing in elderly. Effects in pregnancy, because if we are giving anything to the mother, it's crossing the placenta, it's going to the infant also. After delivery, sometimes the infant can have a floppy infant sort of a presentation. And discontinuation symptoms might be visible in neonate also. Just last one slide on about the Z drugs, because Z drugs initially when it was marketed as safer alternative to non-dependence causing sedatives and hypnotics. But I think we have had multiple cases where we have seen Z drug dependence also. So Z drug includes your zolpidem, zopiclone, your S-zopiclone and your zalpalone. Again, they bind to the GABA A receptors that contain the alpha-1 subunit. Only the alpha-1 subunit containing GABA A receptors. They might have a digital binding site, but we are not aware of that. Again, trials and studies are all going on. They have abuse potential. So earlier, what was said about them that they are completely safe. no, that's not true. Abuse potential exists for Z drugs also because it has a subjective drug liking effect. Yes, they have very unique neuropsychiatric effect. I think the one thing that we all know is sleep related disorders. Patients complain that after starting Z drugs, they sometimes have very vivid dreams, have very bad dreams. So that is something very common. It has some degree of psychostimulant effect, can cause sleepwalking in certain patients, and can trigger de novo OC symptoms also, and has very similar withdrawal symptoms. The one thing that we need to keep in mind is to calculate the diazepam equivalence while managing such cases of Z drug dependence. Again, we have to convert Z drugs into long acting benzodiazepines, specifically diazepam, and then we can take a slow taper. So my last slide for today, take home points. The major CNS effects of benzodiazepines: sedation, it can be a hypnotic, anti-anxiety, anti-convulsant, muscle relaxant. Basically, these are the pharmacological uses of benzodiazepines as a class of medications. Addiction potential, definite. There is a very high rise in addiction cases of benzodiazepine that we are seeing nowadays. Can be given in low doses for 2 to 4 weeks if necessary. So the rationale behind that, initial 2 to 4 weeks, benzodiazepines can cover for the anxiety and depression till your SSRI is on full flow. Once SSRI take over after 4 to 6 weeks, it's not advisable to continue benzodiazepines because the risk of dependence increases tenfold or even 10 to 15 folds if you continue more than 4 weeks. Thank you.
Thank you, Dr. Astut, for a very lucid presentation. Now I'll request our participant to ask any questions or any comments regarding the session. Any queries that you have in the pharmacology of benzodiazepine?
Hi, I have a query. It's not particularly related to the pharmacology, but it's related to the disturbed sleep architecture due to benzodiazepines and Z compounds. So, in my clinical practice, also, I've seen many patients who complain of having vivid dreams after starting benzodiazepines and even Z compounds. And I know it's more of with melatonin after starting melatonin also. So then it becomes very difficult to decide what to do because again, they have sleep problems and we have these options only to give them. So
Right.
how to handle that problem?
Mostly in my clinical practice, at least what I have seen is these are some side effects in which tolerance develops usually. So if the patient persists at least for 7 to 10 days with these medications, although the vivid dreams and the bad memories and sometimes those sort of things that patient describe, a tolerance will develop to that. But again, most of the patients don't want to continue because the autonomic arousal associated with that is so bad. So usually what we do is we try to switch them to some other drug like melatonin. You said one thing. Melatonin, personally, I didn't had so much of complaints about the sleep architecture and other parasomnias. But again, if patients are not tolerating that, low dose of antipsychotics, which includes your quetiapine or amitriptyline for that matter, we can switch to that.
I've tried imipramine and like it has worked. Like imipramine better than amitriptyline.
Correct. It can work depending on the patient profile, ma'am. Definitely.
Okay, and I was hesitant about, like, I've always been hesitant about starting antipsychotics. Like in our last session, also we discussed about low dose quetiapine, where sir said that it should not be prescribed.
Correct.
Low
Correct.
dose quetiapine should not be prescribed for sleep.
Correct, ma'am. So this is something that is a third resort or a fourth resort if your normal pharmacology is not working or someone is not tolerating. Absolutely, I also agree with sir that unnecessarily prescribing antipsychotics to someone just for sleep purposes is not a very good rationale for it. But again, there are certain groups and certain clients of patients we don't respond to your very typical your benzodiazepines, your melatonin, your Z drugs, then your low dose of TCAs. Then after that, if they are not tolerating all those things, very elderly patients sometimes who don't tolerate your amitriptyline, they can develop very bad anticholinergic side effects and other things. Then we have to look for some other options. Right. Now there are different classes of drugs like lemboraxant and other things, the dual orexin receptor antagonists. So probably that is one thing that we can try.
Okay.
Right. Thank
So
you.
we have question from Dr. Atul. Sir is saying like in Kerala, they are seeing two tracks of nitrazepam dependence: iatrogenic overprescribing and polysubstance users chasing hallucinations.
Yeah.
Why this specific preference over other benzos in both groups?
I mean, that is an answer that I am also trying to find, sir. We have asked our patients about the subjective highs, that what are the subjective differences when we give them diazepam or lorazepam versus when they take over the counter or they take illicitly obtained nitrazepam. What they say and what they have described is they feel a sudden high that they don't feel with diazepam, they don't feel with your lorazepam, and then after that sudden high, they have that increased confidence, and then they have that increased risk taking. So again, background of externalizing spectrum, they have that increased risk taking and other things. Again, very specific answer I might not be able to provide, sir, because I myself not know that answer. But again, this is some what many of our patients, not some actually, many of our patients have reported, specifically the class that you mentioned, the polysubstance users who have tried multiple substances in the background, possibly something to do with the fact that they have tried so many substances in the background that their brain chemistry has altered, and then nitrazepam is giving them some different sort of a high. Something to look at, sir, but I am not very sure. And then there are your therapeutic drug dependence and other things. Yes, that is something.
Like what I'm aware of is nitrazepam has more sedative potential, and it also gives that dream-like states.
Correct.
And possibly maybe that is why the potential abuse potential is high there.
Yeah.
I mean, regional wise, even I'm not sure. Tathagat sir, any input into this? Like why nitrazepam abuse more in certain areas?
Actually, in my tenure at Chandigarh, also I have found many people they are preferring nitrazepam, and here also I find so. It is probably the rather than your regional differences, it is probably there is something associated with the drug itself, like high potency is can be one cause, which Dr. Babli has also told that, and many a times euphoria that nitrazepam and your what another alprazolam. Nitrazepam and alprazolam both has some euphoric effects associated with them, and these two benzos are very frequently abused. And another thing might be that people who are using some kind of stimulants, they often use nitrazepam together for a kind of speedballing effect, so these things maybe, and the euphoric effect is not that much prominent with other benzos, so that's why that might be plausible explanation for this thing.
Okay, yes. Okay, we have question with Dr. Ravi. Sir has asked, liability of dependence depends upon peak to time to peak or elimination half time.
Again, both things, sir. So why people start using is how fast they can get the high or the peak. But again, the dependence or the withdrawal, at least the withdrawal part per se, depends on the half-life. Because usually what we see or study about the drugs is 4 to 5 half-lives it takes for complete clearance of the drug. So usually by 4 to 5 half-lives, if you have something of a molecule like diazepam, so withdrawal symptoms will come after 7 to 8 days sometimes. Alprazolam, again, it can come within 12 hours, 12 to 15 hours in that sense. So that's why withdrawal symptoms depend on the half-life. But again, the potency of or the potential of abuse depends on how fast the high can be reached with the drugs.
Next question by Bhavnesh sir. How to effectively handle therapeutic dependence? It's mostly for therapeutic dependence.
So again, what strategy I have used, sir, in that cases is counseling the patient before starting benzodiazepines, that this is a medication that we are giving for a very acute coverage. Although you might feel that you are 100% better with these medications, but these medications may cause some harm if not if taken after a very long after a prescribed period of time. And again, calling them initially when I started benzodiazepine, so calling them initially once in 2 weeks or once in a month and tapering that doses and telling them that we have started another medication to cover for your anxiety or depression, because that is the most common combination here, SSRI plus a benzodiazepine. And then making sure that I don't go more than 4 to 6 weeks with a benzodiazepine. Although sometimes patients might come and ask that, no, this is the medication that was helping me, you stopped it in the last follow-up. But then again, to counsel them, to teach them other non-pharmacological techniques to manage their anxiety, and to tell them that the medication that we have started, this SSRI will take care of the anxiety in the long term.
And next question is, in clinical setting, is lemborexant effective in benzodiazepine dependence?
Again, sir, lemborexant I have not used in many cases per se, but what my colleagues have used and what the discussion I have had, yes, they are seeing very good results with lemborexant, because it's a new molecule, it's a new pathway that we are targeting. It's a new class of receptors. So benzodiazepines, usually what we try to do is we try to play with histamine, we try to play with GABA. So we give some GABA modulator to manage for benzodiazepine. We give pregabalin, we give gabapentin. So again, what happens in patient mind is try to compare that, oh, with that I was sleeping so well, with this I'm not sleeping that well. So what they have done, at least in cases of lemborexant, yes, by blocking the orexin, both the orexin 1 and orexin 2, the sleep quality definitely has improved, and patients don't come back and ask for additional medications. At least they come and ask for just to continue this medication, but they don't ask for additional medications or dose increments and other things. So I think definitely lemborexant has some role in benzodiazepine dependence also.
And it also depends on that we have discussed. I mean, maybe in next few sessions we'll discuss. We'll have to look for why benzodiazepine dependence have developed. Like if we are dealing with a primary insomnia, then we can use this agent. But if there is some underlying disorders, then we have to deal with that. Regarding that, there's also one question by Dr. Ravi. Like, why has FDA approved benzodiazepine for anxiety?
Again, FDA approval for benzodiazepine happened, I think, somewhere around 1978 or 80s. I'm not again very sure. When the benzodiazepine was advented, it was thought of as a magic drug, and it was actually marketed. There were some songs and marketings also that it was known as a magic pill initially, because it would cure the anxiety and other things very quickly. But again, this is for acute management of panic, and not just for anxiety. There are multiple other sort of anxiety spectrum disorders also, like panic attacks and other things, where sometimes we need to use SOS benzodiazepine because there is no other way. Benzodiazepines are the quickest way to terminate a panic attack, to control the anxiety. So your SSRIs, your other things, it probably doesn't help that much. So that's why I don't think FDA has done anything wrong by approving benzodiazepine. It's just that we as clinicians should be very mindful of prescribing benzodiazepines.
Although we have more questions in the chat box, but they have a common theme by Dr. Farzana, Dr. Daisy, and Dr. Jubli. It's more like if one has therapeutic dependence for long term, they are using low dose, how to deal with that?
Again, so one thing is you have to start by building a very good rapport with the patient. You have to understand what was their initial motive of use, how benzodiazepine has helped them, because if they have been taking for years and years, it's very difficult for you to even come talk to them about quitting that benzodiazepine altogether. Again, you can tell them that now age is increasing, body physiology is changing, this medication might do certain harms. You need to have a very open discussion with your patient. Again, it has to be a patient-centric decision rather than a clinician-centered decision, because if you will stop benzodiazepine, probably they will fall out of treatment care and would not come back to you and would go to someone who will just continue benzodiazepine. So again, you have to discuss with the patient. What I have found is if the patient is taking at least a high dose of benzodiazepine, somewhere around 40 milliprints or diazepam or something, probably gradually tapering that. Don't tell that we'll stop it altogether. We will very gradually taper. So tell patient that it will be a very slow taper of over 8 to 12 weeks. That is a very short timeline that I'm giving. Sometimes it might go for months to years also. And what at least it's recommended is 15 to 20% every 2 weeks taper. But again, towards the end part of the taper, when the patient is on 10 mg or 15 mg of diazepam, becomes very difficult for patients to get off that. Adding other medications like gabapentin or pregabalin, specifically if the patient is very young. Again, these medications in elderly might have different sort of side effects. To have to be mindful about the patient's clinical profile. And again, it's all to do about discussion with the patient.
Yeah. Right. Actually, in the last case discussion, we have dealt with the we have seen a benzodiazepine case, and we are aware how notorious benzodiazepine can be, and it's a very difficult. Even if you're dealing with therapeutic dependence, it's very difficult to manage that. So, as Dr. Astut told, it should be both patient centric as well, not just our decision. So it should be an alliance, because if we pressurize and if we just taper it fastly, they might go to some other doctor. So it should be a therapeutic alliance that should be there, and then gradual taper or shift into a non habit forming agent, that is an ideal. Okay, so now we will conclude our didactic session. I would like to thank Dr. Astut for his insightful session, and we will move forward towards our next session, that is the Slido quiz. We have shared the link in the chat box. I'd request everyone to kindly join the quiz. So, we'll move ahead with the Slido quiz. Can we have the first question, please? So, benzodiazepines act primarily by? Okay, so majority have mentioned that they act on positive allosteric modulators of GABA A receptors, which is the right answer. So they basically bind at the junction of alpha and gamma, and then like they don't directly bind to the GABA receptor, they at the intersection, and they are the positive allosteric modulators. Can we have the next question, please? Which GABA A subunit is primarily responsible for sedation and amnesia? I think it was discussed in our didactic, in that didactic as well. So, like, although some people are still confused, so can you see the answer? Right. So alpha 1 is responsible for the sedation, amnesia, and also for the anticonvulsant activity. Alpha 2, alpha 3 are the anxiolytic effect. Alpha 3 additionally have muscle relaxant effect, and alpha 5, if we say, they are mostly responsible for the cognitive part of it. Okay. Can we move to the next question? So a 32-year-old male has been taking alprazolam 4 milligram per day for 8 months. He abruptly stops the medication, and within 18 hours, he develops anxiety, tremors, palpitation, and insomnia. What is the most likely explanation? So, withdrawal. So, this is the presentation of the withdrawal symptoms. Like after sudden cessation, the emergence of these symptoms are called the withdrawal symptoms. Okay. Can we move to the next question? Tolerance to benzodiazepine is primarily associated with? Right. So everyone has said it's the GABA A down regulation. So it's GABA A down regulation or increased AMPA activity. These primarily are responsible for the development of tolerance. Can we have the next question? A 70-year-old female presents with confusion, unsteady gait, and memory impairment after being prescribed diazepam for insomnia. Most likely mechanism? It's pretty straightforward question. Yeah. So basically, it's GABA A potentiation, and diazepam being also the long acting, the drug accumulates, and the presentation that we have is mostly like suggestive of benzodiazepine. In a way, we can say toxicity that we are having, which is due to the GABA A potentiation. Can we move to the next question? So this is the last question. Which of the following statements regarding GABA A receptors are true? So this is a multiple answer. Okay, so the house is split here. So can we see the correct answer here? Okay, so basically GABA E receptors, these are the inotropic receptors, GABA A receptors, and they are pentameric ligand gated, and usually the subunits are alpha, beta, gamma. There is delta, epsilon, and rho as well. Mostly pentameric they have. The benzodiazepine, they don't bind at the GABA binding site, they bind at the interface. That is why they are called as allosteric modulators. And it's rightly said the gamma 2 subunit is mostly responsible for the benzosensitivity. And there is also a component of delta receptors. So these are extra synaptic. They are responsible for the tonic. If we see, we have phasic release and we have tonic release. Phasic release, these are the presynaptic GABA receptors where like whenever a receptor is bound, there is release of GABA, and they give the with that, for example, in alcohol or in benzodiazepine use, if someone is, that increases the benzodiazepine sensitivity. For the delta, it's the usual tonic. These are extrasynaptic receptors maintaining the tonic phase, basically for maintaining the action potentials. And for the last option, barbiturates, they increase the duration of the chloride channel opening rather than the frequency. The benzodiazepines increase the frequency of the chloride channel opening, but the barbiturate, they increase the duration. So this is the difference between them. Okay. So can we see the difference? Okay. So we have Dr. Aman Naqvi in the first place. So congratulations, Dr. Aman. Followed by Dr. Ravi, Dr. Rohini, Dr. Bhavnesh, and Dr. Megha. So congratulations, everyone. You will be receiving your certificates through mail. And we will conclude this slider session for now, and we will move forward to our case discussions. So, as usual, we have two case discussions with us by Dr. Indu and Dr. Ravin, and we have with us Dr. Aishwarya. Ma'am, Dr. Aishwarya Rao, ma'am, she is assistant professor at Father College, Medical College, Mangalore. Ma'am, I hand over the stage to you for the case discussions.
Thank you, ma'am. Now, shall we proceed with the first case? Dr. Indu Marti. I think she's presenting a case on opioid dependence syndrome. So if you can start presenting, we'll carry forward with the discussion.
Ma'am, you will be given 10 minutes for presentation, and at the 8th minute, we'll be providing you a reminder of the time, ma'am.
Okay.
Sure.
Good afternoon, everyone. I am presenting case of Mr. XYZ. He is 46 years old male, illiterate, married, truck driver by occupation. He belongs to lower middle socioeconomic status and resident of Saharanpur. The second informant is Mrs. Y. She is wife of the patient, 40 years old female, illiterate, and a housewife. She is currently staying with the patient. Please. Now, reliability of the information. The information provided by both of them is reliable, and source of admission is Addiction Treatment Facility (OPD) Saharanpur. He is admitted on 8th of October 2025. Reason for admission was he was unmanageable at home, so he was admitted for further evaluation and management. And reason for presentation was to discuss further medical and psychosocial management. Now the chief complaints, he was presented with chief complaints of स्मैक का नशा करते हैं, टोबैको का नशा करते हैं, नशा छोड़ नहीं पा रहे हैं और नींद कम आती है. The onset was insidious, course was progressive, duration was 20 years for tobacco and 15 years for smack. It was first continuous episode and precipitating factor was peer pressure. Treatment was taken through ATF OPD in the form of tablet buprenorphine 2 mg BD, tablet clonazepam 0.5 mg HS and tablet quetiapine 100 mg HS. Now the current pattern of substance use was he was taking tobacco, chewable tobacco in around 4 to 5 packets per day, and the last use was 1 day before the admission. And he is also taking opioid in the form of smack, that is around 1 to 1.5 gram per day. He was taking this substance by chasing on aluminum foil, and he used to take these doses in around 3 to 4 times per day. Last use was 1 day prior to the admission. Now the history of present illness. He was apparently asymptomatic and well adjusted to personal, social and occupational life. About 20 years back, when he started taking chewable tobacco, his first experience was with a group of friends who first introduced it to him. He enjoyed the effect and then started taking it to 1 to 2 times per week and gradually increased its frequency to 4 to 5 times per week in last 5 years. For the past 15 years, the patient had regular intake of 4 to 5 packets per day as there was easy availability. On tobacco, he never attempted to quit it or decrease its amount. He also tried smoking tobacco, but due to his breathing problems, he has to quit it after use of 8 to 10 years. Whenever he decreases the amount of chewable tobacco, he would feel craving for the substance, experience anxiety, constipation, difficulty in falling asleep. He would have intense craving for chewable tobacco during day and night, and he never attempted to quit it or even cut down the amount of tobacco that he used to take. He also used to take alcohol since the age of 20 years, 3 to 4 times a week. He used to take country-made liquor 1 to 2 quarters per day. One day he was going to take alcohol from the shop when his brother-in-law convinced him to try a little bit of smack instead of alcohol. He said its smell would not be detected by the family members and also gave him more pleasure. The patient had tried taking smack with cigarette and 0.25 gram was distributed in 3 other people with them, and he experienced dizziness and intense pleasure after the use. Gradually, he came to know that it will give more pleasure in chasing it on aluminum foil rather than smoking. As he enjoyed the effect, he started chasing the smack and used to take 0.25 gram of smack 2 to 3 times in a week and with gradual increase to 1 to 2 times in a day over the period of 5 years. He would not mix smack with any injectable or other substances. Initially, he would consume smack whenever he goes to drive truck, but after few months, he started taking on his non-working days as well. He would spend around 500 to 1000 rupees per day for procuring smack. Whenever due to financial constraint he was unable to take smack, he would experience body ache, increased lacrimation, tremors, disturbed sleep, and breathlessness. There is no history of any complicated withdrawal. The patient would mostly consume smack during day and night, but whenever he was unable to take, he would consume more tobacco. Currently, for past 1 year, the patient is consuming mainly smack around 0.25 gram to 0.5 gram in 3 to 4 times divided in divided intake. It costs around rupees 1000 to 1500 per day to the patient, which increases to 1 to 1.5 gram per day since past 6 months, costing around 1500 to 2000 per day. His tobacco intake is around 4 to 5 packets per day. His last use of both smack and tobacco was 1 day before admission. He was so indulged in taking smack that he was not going to his work since last 15 days. As per his wife, he used to say that he would go for work, but he would not. In place of going for work, he would go to his friends and came home at night in intoxicated state. His wife and his relative consistently tried to make him understand the consequences of substance use and how badly it affected their financial state, but he would not listen to any of them. Despite knowing all of the ill effects of the substances, he couldn't refrain himself. He would frequently quarrel with his wife regarding substance use. In between, he started spending less time with his family. Uh, his relatives and neighbor also started talking bad about him at his back regarding his smack use. During 4 to 5 years, the patient has also started having financial problems as he would spend most of his earnings in procuring smack and have difficulties in meeting family demands. During the course of illness, the patient's sleep and appetite also got reduced. Earlier, he used to sleep around 8 to 9 hours a day. Gradually, over the years, his sleep reduced to 3 to 4 hours. Earlier, he used to eat 3 meals a day and snacks in between. Gradually, he started skipping his meals at lunchtime. Later on, he would take meals only once, that too when forced by his wife. His sexual activity was also reduced as he would engage and spend more time in substance use. Due to significant impairment in social, personal, and occupational life and repeated persuasion by his family members, the patient attempted quitting and developed withdrawal symptoms in the form of breathlessness, anxiety, tremors, and disturbed sleep. When symptoms became unmanageable, he decided to seek medical assistance from ATF OPD, SBD Saharanpur, and got admitted. He was started on tablet buprenorphine 2 mg BD, tablet clonazepam 0.5 mg HS, and tablet quetiapine 100 mg HS. After taking these medications, he reported improvement in his craving, sleep, and appetite. Now, the complications and consequences from the substance use. The physical consequences was aggravation of his asthma, ill effects on body, and disturbed sleep. The psychological consequences are in form of decreased sleep, appetite, anxiety, and mood disturbances. Socioculture was his marital issues, less respect among relatives, and occupational was around that he may lose his job, and financial consequences are in form of financial instability due to excessive substance use. There was no legal complications at present.
Dr. Indu, 2 minutes are remaining. You can tell us the important points.
Okay, can we shift to the diagnostic formulation or biopsychosocial?
Any significant
As
points?
it was not no significant family history was present. There's no significant comorbid personality or something like that. Scales, yes. Now the diagnostic formulation, as general and systemic examination was within normal limit. The patient was in preparation stage of motivation, and the locus of control was internal. The provisional impression was mental and behavioral disorders due to use of opioids, dependence syndrome, currently on a clinical supervised maintenance or replacement regime, with mental and behavioral disorders due to use of tobacco, dependence syndrome, currently on a clinically supervised maintenance or replacement regime, with asthma and hypothyroidism as per ICD-10 criteria. Investigation was within normal limit. Now the points in favor was he's fulfilling the criteria that he has strong desire or sense of compulsion to take substances. He's having difficulties in controlling substance taking behaviors, and also he has physiological withdrawal state whenever he failed to consume the substance or decrease the amount. He has he has symptoms of development of tolerance, and he neglect the family and his child whenever in as due to indulging in the substance, and despite knowing the harmful consequences, he used to take the substance. Now, the biopsychosocial formulation. In biopsychosocial formulation, there are some points which I want to focus on. The main things are psychological points in which he has poor coping, as he also had taken treatment from ATF OPD 2 years ago, but he stopped the treatment in between. because of the poor motivation and poor coping skills. And then after 2 years, he again visit the OPD and got admitted. So I want to focus on that point so that we can plan the treatment. Currently, he's on management. He is on tablet buprenorphine 2 mg BD and clonazepam 0.5 mg at HS. For pharmacological, I want to discuss the prevention. What can we do to enhance the motivation more, or to make the patient adhere in the treatment?
Aishwarya ma'am.
Thank you, Dr. Indurani, for a detailed presentation. You have beautifully explained the biopsychosocial model and all the factors responsible for it. So the floor is now open for discussion. Anybody has any doubts, any clarifications that you want to ask Dr. Indurani? You can unmute and ask, or you can also ask in the chat box. So it's one of the most prevalent in North India, right? Especially in Punjab region, this opioid dependence is becoming a hassle these days. So any one of you have any experience in handling such cases? Because in South, especially in the region that I work in, we usually don't see much opioid dependence. Alcohol, tobacco is more, and cannabis is on the rising trend these days. Opioid dependence, anyone has any personal experience to share?
Yeah, ma'am. I had actually seen one patient who was using, he was from Kerala, our place only, but he had gone to work in Karnataka. So at that time, he was working in a shop. So the other sales person who were working with him, they were at the time when he was joining, he saw them using some IV substance, and then they told them that it's easier if you take this, you can work better, you'll feel fresh. And so ultimately, he over around 4 years he continued using that. He ended up having dependence, and then eventually, then his mother had some eye operation, and for that he had to come here. And then while he was staying as a bystander along with his father in the hospital, he had started having withdrawal. So he was having insomnia, and then irritation, and all those, and that was the reason why he had presented here.
Okay.
And so then we had basically managed him symptomatically. He was using that that substance, man. One tablet is there, one opioid tablet,
Tapentadol.
Yeah, that he was using. So what they used to do was they would buy the tablet, and then from the pharmacy they'd buy the insulin syringe, and then they'd actually crush the tablets, and then in saline they'd mix it with this thing in the syringe, and then they'd inject it. And to prevent this from forming this thing particles, they'd actually before injecting they'd actually aspirate some blood, and then with that, so that dissolve in the blood, and then they'd inject that.
So it's an interesting case. I mean, all of us should be more aware in our daily OPDs to check for any other substance. Nowadays, it's becoming increased prevalence. Okay. So here, Dr. Indu used the word smack, right? So it's a common street name. So smack is used for what substance? Any idea?
Heroin.
Yeah, heroin. So any other street names that you know, we should be as psychiatrists aware of the common street names used for these drugs. They might come and use the term. So what are the other common street names for heroin that you know of? Smack, brown sugar, some call it junk, or chitta. These are commonly used in North India, right? And apart from that, apart from heroin, morphine, it's called as afim, doda, post, madak, and oxycodone as oxy and OC. These are the common street names that we come across. So here, Dr. Indu explained chasing. So do all of you know what chasing is? How is heroin taken in the form of chasing? So chasing is basically there's an aluminum foil and they use this heroin on that and they light up the foil from below. So it turns into liquid and with a paper roll, they inhale the smoke coming from it. So it's called chasing because as it flows, they chase the liquid which is flowing and then they inhale the smoke. So that is chasing. It is one of the commonly um, common methods of inhalation of heroin. Apart from this, any other common methods that are there?
Snorting and
Sorry.
injecting or snorting.
Yeah, snorting, injecting. Usually chasing, snorting will start first, and if left untreated, it might not give the same effect, and later it will go into more harmful forms such as injection. Injection will give acute effect and rapid onset, whereas this gives a relatively lesser effect. And Dr. Indu, what is the current follow-up of the patient? Are they still following up with you?
Yes, ma'am. He's currently in follow-up, and now he's on tablet buprenorphine, 2 mg, half BD.
Okay. So
Decrease
slowly
the
you're
dose.
trying to
Yes, ma'am.
decrease it.
Yes, ma'am.
So usually in your practice, what regimen do you follow to decrease once you start on replacement, how do you go down on the tablet?
Ma'am, if we plan the patient to be on maintenance treatment on tablet naltrexone, then we used to slowly taper the buprenorphine in 2 to 3 days on around 0.84 to 0.8 mg per day, and then we keep the patient off from buprenorphine in around 6 to 7 days, and on seventh day we start as 25 mg OD. Naltrexone 25 mg OD. Then if he reports improvement and no any significant withdrawal, then we start on 50 mg OD since other day.
And we'll also have to look out for LFTs before starting
Yes, ma'am.
naltrexone as
Yes,
well,
ma'am.
right? Yeah. And there's one more form of buprenorphine and naloxone combination. Have any of you tried that combination tablet of buprenorphine and naloxone?
I have tried it in around 2 mg of buprenorphine and 0.5 mg of naloxone.
Yeah, it is usually in 4:1 ratio, right? Buprenorphine 4 and naloxone 1. Any idea why this combination is used? So naloxone has a poor sublingual bioavailability and buprenorphine has more sublingual bioavailability. And naloxone's uses are predominant when given IV. So this we use it to prevent IV abuse of that drug, to prevent crashing as Dr. Major was describing, to crush the powder and use it as IV form. To prevent that, this naloxone has adverse effects and patients use it in the form that is used and they don't take that for IV drug abuse. So that is one of the common reason why this combination is used. So, and other non-pharmacological managements that you have tried for this patient?
We have psychoeducated the patient as well as his wife for the long-term treatment, need for long-term treatment and regular follow-ups. And also we have counseled the patient that as he is asthmatic, so we also keep this thing in mind that we should not reduce the buprenorphine below the range so that he get affected, because it results in increase the symptoms of his asthma. Whenever we tried to reduce the dose, his experiences started having breathlessness and all these things. So we also try to manage these things, and we plan for motivation enhancement therapies as well.
Yeah, as you beautifully described in your biopsychosocial model, each of these points can be taken in our non-pharmacological intervention also, right? In our motivation enhancement therapy, relapse prevention techniques, administering all these, thinking about all these points and addressing it will help to prevent further relapse and helps in patient retention as well. All right. So any other doubts, any last doubts, anything before we proceed to the next case? We'll come back to this due to shortage of time. Faculty, Dr. Bubbly, Dr. Tathagata, any inputs on this case?
Like, I think the most important part is the retention of this patient. So if they're and there is predominant opioid use is there, and it's also challenging. So we have to look why, as Dr. Indu also mentioned, he was lost to follow up. The reason for why he didn't come, was it the dose adequate, or were there some other issues that were going? So we have to explore that, and then adequately, if we give the buprenorphine dose, then maybe we will be able to retain him if the craving will be managed. So this part, it also needs to be explored. And as Indu ma'am mentioned, that there's no comorbidities, but please look for any other, if we are having any other impulsivity or any other externalizing things that are there. So if that could be addressed, that could be things. Any other thing, Tathagat sir, in this case, any comments?
Hi. Exactly, Dr. Babli. So I don't know the exact duration of his opioid use, but from the history, it seems that at least he is using for last 5 or more years. And he's consistently chasing heroin, and currently he's chasing around 1.5 to 2 grams per day. So in this case, actually, a rapid tapering off and shifting to naltrexone may actually increase the dropout rate only, rather than successful maintaining in the treatment loop. So that thing needs to be considered before comprehensively managing the case. And yes, the dose needs to be adequate, because half-hearted, OST may just increase the suffering rather than proper maintenance. And as the person is a truck driver, so the treatment retention needs to be evaluated, and if possible, the take home can be adjusted accordingly, so that he can maintain on the treatment loop. That's all from my side, and of course, you need to look for the comorbidities and address those things adequately.
So can we have the next presentation, Dr. Avin? Since we have shortage of time, can we have the highlights or the important points from your case discussion, and then we can revolve our discussion around that. Will that be okay, Dr. Avin? Okay, Aishwarya ma'am, can we do like that? The important points and then discussions around
Sure,
that.
ma'am. Sure, ma'am.
Okay, over to you, Dr. Avin.
Am I audible now?
Yes, yes.
I will share the screen. I think there is animation.
Yes.
Okay. Is it visible?
Not yet, sir.
When it's loading.
Okay, then, ma'am, you can share the screen. I have stopped sharing. Okay, this is the case of 40-year-old male, educated till 10th standard, from lower socioeconomic status from Puducherry. He works as a cobbler and informant is spouse. Information is reliable and adequate. Next slide. His chief complaints is inability to stop alcohol for 20 years, tremor, sleep disturbance, palpitation after stopping alcohol for 15 years, repeated unwanted checking or appraisal of his work, especially work-related cobbling, counting of money and locks for 15 years. The patient has been taking alcohol for around 20 years. Initially, the frequency was only once, weekly once, and he started it after his acquaintance exposed him to him. Though the frequency was initially weekly once, the amount started to increase from average of 3 units to 9 units during the next 5 years. After 5 years, the alcohol use, he started to increase the frequency from once a week to 3 to 4 times, as it helps, according to him, it helps to mitigate anxiety related to work. Over the next few years, his frequency increased to almost daily, and for the last 10 years, it has been the same. The average intake has been around 16 units during this period, and the last intake, when I took the case, he was absent for 2 months. Patient is a lone drinker in the latter years of alcohol use, with patient sometimes starts to take alcohol in the morning too. However, the frequency of it couldn't be elicited. Patients frequently initiates alcohol intake when there is an anxiety-provoking situation such as delay in work or debt. Patient continues to take alcohol to an extent that hampers his daily commitments and results in frequent interpersonal relationship issues both in work and home. After months, when he starts developing tremors, palpitations, sleep disturbances, he tries to stop alcohol after there is a lot of disharmony at home and at work, and he seeks treatment then for a few months. During the period of abstinence, which may last for weeks to months, his wife has noticed he repeatedly checks his completed works, especially his cobbled shoes, zips of the bag that he cobbles, etc. Many times when asked about it, he would become irritable and avoids answering. This has hampered his pace of work and hence a backlog, resulting in anxiety, and this is the most common for relapse, forming a vicious cycle. Wife has noticed him to have such behavior and counting money repeatedly. However, she denies any other repeated activities such as washing, nor patients have complained of repeated impulse or images. Patient also reminisces that during the periods of alcohol consumption, his intention to repeatedly checking comes down and he feels more confident of his work. Currently, patient has visited hospital for his increased severity of tremors and sleep disturbances, and this time because her children are grown up, they question his alcoholic behavior and it creates a social embarrassing situation. During this period, he has not developed any withdrawal seizures or features such as delirium tremens. He has had no history such as alcohol, liver disease, melena, or any legal issues, road traffic accident during this period. No history suggestive of other obsessive compulsive related disorder or anxiety disorder. No other substance use. Complication from substance use. Psychologically, anxiety as a part of withdrawal and repeated checking during abstinence has led to a vicious cycle of his alcohol behavior. Absenteeism, work delay, loss of customers was an occupational aspect. Family, there was frequent fights over alcohol behavior and critical comments by family members. Financially, because of his work inefficiency, there is a lot of debt and embarrassment from financiers. Yeah, there is no past medical or psychiatric conditions. When he visited us, we treated initially for simple withdrawal. We maintained a fixed dose regime. After 2 months, we are maintaining only on the low dose lorazepam, that is 2 mg once daily, escitalopram 20 mg once in the morning, pantoprazole 40 mg, thiamine, and baclofen. Family history, salient features is family history such as generalized anxiety disorder in mother, no substance use in father. He has 4 brothers, and of which 3 of them had ADS, and 1 also had history suggestive of generalized anxiety disorder. It's personal history. Details of childhood was not available. However, he grew up with the parents. Cobbling was taught by his father. He dropped after 10th standard because to support the family. Another important thing is there is family disharmony, especially there is frequent fights regarding his alcohol behavior. Though wife acknowledges his sincerity to work and anxiety he suffers. Next slide. Pre-morbid personality. Patient is a shy, aloof person who has close friend circle. He attends social gathering, but always he likes to be a silent observer. According to wife, he is very relaxed, but when given a situation that requires decision making, etc., he becomes anxious. Many times he is comfortable asking reassurances. Other aspects of personalities are in many critical situations, he asks his wife to decide. Whenever given a problem, there is a lot of what if questions. What if, especially in the pessimistic way. He is sincere in work and very meticulous. Wife noticed that he is very particular in doing things in the right way, especially when it comes to parenting children in dressing, schooling, and habits. Physical examination was nil significant. Next slide, please. No withdrawal symptoms was noted because he was absent for 2 months. In MSc, the salient points was the possession of thought. I have a repeated thought that whenever I have done a job properly, though I know I have done it, I keep on checking again and again. Initially, I felt it was necessary, but nowadays it is very distressing. Sometimes I do it for counting money too. As far as content, motivation, the locus of control of substance use is external, attributes to the anxiety. Motivation, since he is into treatment for 2 months, I have kept it as action. Next slide. A higher mental function test, insight, awareness of the illness is present. He attributes to external factors, and acceptance of treatment is present, both for the alcohol behavior and the obsessive compulsive symptoms. Investigation at the time of when he comes, AST and ALT was increased, bilirubin was normal, and other investigations was normal. Yeah, this is a summary. 40 years old, educated till 10th standard, pre-morbidly suggestive of anxious trait, presence with history of inability to stop alcohol, withdrawal symptoms and tolerance, and repeated checking of his work. Family history of generalized anxiety disorder in mother and one of the brothers, and alcohol dependence syndrome in brother. No other substance use, no history of any organicity, history of interpersonal relationship issues because of alcohol behavior, financial work-related issues. Physical examination nil significant. MSc, we had disorder of thought possession, obsessive doubt and checking. Locus of control was external, motivation was action. Higher mental function test was nil significant. Insight was partial. As far as diagnosis is concerned, alcohol dependence syndrome, early full remission, alcohol withdrawal uncomplicated, obsessive compulsive disorder, fat to good insight, and mild personality disorder. Next. So management, we currently patient is 2 month abstinent. Initially, we started him on detoxification with fixed dose because he wanted OP treatment. Patient was started on baclofen. This was based on purely on affordability and availability. Patient was also started on low dose, the minimum dose of SSRI for OC symptoms. During the follow-up, we had reduced the lorazepam based on his withdrawal, and we understood that OC symptom must be addressed to avoid the relapse as it was the locus. Next slide. Psychological brief intervention was done by the psychologist. Psychoeducation about alcohol, focusing on craving and relation with relapse and OC symptoms was explained. His understanding of obsession was initially was not there. He was very much, he could understand compulsion, but we psychoeducated about the obsession. The plan was to a personality assessment, Y-box, and plan exposure response prevention in the follow-up visits. Motivation enhancement was yet to be implemented. Finally, it has not come. Finally, I like to conclude by the first one is actually predisposing factors. That is anxious personality, family history of anxiety and alcohol dependence. Precipitating factors are the OC symptoms and poor coping skills to stressors. Perpetuating factors are anxiety symptoms, where he used alcohol as self-medication, and the withdrawal symptoms. Protective factors are good family support, insight, and adherence to treatment. Thank you.
Thank you, Dr. Ravin, for presenting such an interesting case. The floor is now open to participants. Any doubts or any clarifications you want to ask Dr. Ravin? I had one doubt, Dr. Ravin. The anxious,
Yes.
is it just his personality, or is there a GAD component also? And because we don't know whether anxiety started first, OC started first, then alcohol started, or first alcohol started and then these symptoms came up.
Yes, ma'am. True. The onset of symptoms is not very clear. And I like to add one more interesting point because I'm following him for last 6 months. Actually, the OC symptoms has reduced very much. He's been abstinent for 6 months. So whether it is a drug-induced OC symptoms is also a question to ponder.
Okay, so
Uh,
alcohol-induced anxiety
OC
disorder
symptoms is
or
also
OC
possibility.
symptoms also you're thinking of.
And GAD could be whether it is a personality trait or a generalized anxiety disorder. I couldn't establish.
Okay, maybe in further follow-ups, maybe you can concentrate more on that
Yes,
and address that. I think the management of anxiety here is the key, the OC symptoms or
yes.
anxiety to prevent his relapse. And any clarification more on the OC symptoms? There is this checking OC, but is it actually an obsession or is it anxiety or is it obsessive rumination?
Ma'am, the initially phenomenology was very similar to obsessive checking, obsessive doubts.
Okay.
But now the symptoms has withered off very fast. So again, that is a point of confusion.
So with escitalopram, he has shown improvement.
Yes, ma'am. Yes.
Baseline Ybox, was it applied?
Ybox baseline was 38.
38.
And now it is around 8.
Okay, so it has reduced. So he seems to have a lot of cluster C personality traits as well,
Yes,
right? Anxious, dependent, as well as some OC components are also there. And yeah, so I think the key here is managing the anxiety.
Anxiety.
Yeah. Any other inputs from any other participants? And one more point is this patient might be prone for benzodiazepine dependence also, because now
Yes,
you have started him on lorazepam 2 mg that will reduce his anxiety. So I think we should be little careful on that, listening to today's didactic. So
true.
Any other points? Any inputs from the faculty, Dr. Bubbly ma'am, Tathagata sir?
I think for this OC part as well, like we need to clarify, these are the symptoms. What you have presented to us seems like OCD only. You mentioned that there is a rapid resolution on these
Yes, ma'am.
symptoms.
Yes, that is a this point of discussion actually.
I mean, after what? I mean, how many days or weeks of therapy?
Yes, ma'am. He's been continuously following up with us for 6 months, and for the last 2 months, OC symptoms has reduced.
Okay, then I mean, it's fitting to the usual trajectory. You are saying for 6 months it was there, and from last 2 months only it has reduced. Is
Yes,
it?
yes,
Okay.
yes, ma'am. And it corresponds with the period of abstinence also. So that also has to be considered.
That
So
means
that is why whether it is drug induced or independent OCD is a discussion.
but like alcohol is not likely to
Yes.
cause OCD, so it looks
That is
like
the reason why I actually presented this case. This very rarely we see, and we also gave only escitalopram 20 mg. We didn't even increase the dose. So that is the thing.
And what are we doing about alcohol right now?
Currently, he's on baclofen 60 mg, ma'am, and escitalopram 20 mg. Only brief intervention was done. He in the last 6 months he relapsed for approximately 2 or 3 days, especially again similarly during an anxiety-provoking situation. Other than that, he is maintaining well, and we didn't have the opportunity for motivation enhancement therapy.
But he has been fairly abstinent and he is able to
Yes,
maintain abstinence. So
yes,
what we
yes,
focus mostly on the relapse prevention.
yes,
Also to have a relation what is happening with his OC symptoms and alcohol use, or like what is the correlation between those. So these
yes.
you could relate and then make up a relapse prevention plan. I mean, this is what I feel. Anything else, Tathagat sir, in this case?
Hi. So it's definitely an interesting case that someone who is who has been using alcohol for a long period of time and had dependent, anxious, and reassuring seeking trait from the very beginning. Noticed that yes, whenever he's not using alcohol, he is having some OC kind of symptoms like repeated shaking things. But otherwise, as per your history, it seemed that it was not that much affecting his socio-occupational things. He was more or less maintaining well, but he became conscious about his alcohol use, and he himself presented, he himself sought treatment, and uh, once he got abstinent with intermittent lapses, uh, and maintaining abstinence for last 6 months, he noticed that for last 4 months, his OC symptoms, that kind of repeated shaking things, improved significantly without much help, although the acetylopram is there. So now, if we consider something as induced as per ICD classification, then the thing is that one is temporal relationship, and the temporal, as per the temporal relationship is concerned, the thing is that after stopping the offending agent, this should preferably recover on its own without any medication within 1 month. But that thing has not been observed in this case, isn't it?
Yes.
Huh?
I just followed the old ICD-10 criteria, which says 6 months. So that is the reason for me thinking like that.
Okay, but what is the current conceptualization? And another thing which Dr. Babli has highlighted, that biologically, alcohol is not supposed to induce an OC
Yes.
symptoms, but the OC and alcohol can have the common biological underpinning,
Yes.
like CSTC circuits.
Yes.
Okay, so considering all those things, that his OC symptoms took at least for 2-3 months of complete after complete cessation of alcohol, and after adding your escitalopram. So probably it I won't be keeping the alcohol induced OC as a diagnosis in this case, but I would certainly keep alcohol use disorder as well as OC or anxiety, some anxiety spectrum disorder as a comorbid case. And as you have conceptualized, and the patient has also told that alcohol is improving his anxiety, and that is a driving force of using alcohol.
Yes.
Okay, so probably the thing is that as escitalopram has reduced anxiety, then it has helped him to abstain also.
Yes. Yes.
He got confident that okay, I have another tool in my hand. I have a more effective agent to control my anxiety, and that's why I can leave alcohol confidently. Okay.
Yes.
So I would have conceptualized the case in this fashion.
Oh,
So
fine.
it is you have done a very good job, I would say, that you are following up the patient for last 6 months, and so most probably there has been a very good rapport with you,
Yes.
and the patient is maintaining well, both in terms of psychiatric symptoms, substance use, as well as occupational. It is really gratifying to see this kind of response in such a complex case.
Yeah.
Good job.
Thank you.
Thank you, Dr. Ravi, and thank you, sir. Thank you, Dr. Akanksha, for joining us, and it's been a pleasure for us for you to join. Okay, so and here we will conclude today's session, and I'll hand over to.
Thank you so much. Thank you, Aishwarya ma'am, for joining the session and facilitating the cases. And thank you everyone for joining today's session. With that, we have come to the end of today's session. We'll be having our next session on 6th March. And the didactic presentation will be on the topic Managing Intoxications, Withdrawals and Dependence of Benzodiazepines by Dr. Shivam. We will be having a micro presentation on that day, but on the topic semaglutide human trials for alcohol use disorder by Dr. Gaki, which will be mentored by Dr. Narasimha, and we'll be having a case presentation by Dr. Jubilee Dani. I would like to confirm ma'am's participation for the next session.
Yes, ma'am. I'll be presenting the case.
Thank you so much, ma'am. It will be facilitated by Dr. Jayant. If you have any queries regarding any of the contents or anything, you can mail me at nahma.002751@nimhans.net. We have shared the feedback link on the chat box. Kindly provide us feedback before leaving the session. And once again, thank you all for attending today's session. Have a nice day. Thank you.